Good morning, everyone. Thank you so much for the invitation to speak here today. I talk genomics to a lot of people in a lot of places around the world, but I feel like this is a really different audience, so it's really great to share some of the stuff that we're doing here. So I'm going to be talking about the Melbourne Genomics Health Alliance. So we are an alliance of hospitals, research organisations across Melbourne, and we were brought together in about 2014 really to bring genomics into clinical practice. So genomics is the use of our DNA to understand what's wrong with us, how our health may change in the future, or what treatments might help. And it's been something that's been sitting out there on the kind of promise horizon for a while now. And the heads of these organisations came together and said, you know what, we actually really want this to happen now. We need to start doing this for our patients. So the Alliance came together with that mission to implement clinical genomics into practice. So we did this through a range of things. I think everybody who's ever worked on a tech project knows that tech is not usually the problem, right? It's the change that comes along with it. And Melbourne Genomics really set themselves up as a change program. So we've done a range of things in order to do that. One of those is the technology, which I will talk to you today. The first one was workforce development. So we need a clinically competent workforce that understands genomics, understands when these tests will work, when they won't. We need to be able to adopt new technologies into the genomic workflows really rapidly, so we had to figure out how to do that because this is moving really fast and health technology tends to move really, really, really slowly. So how do we get new things into practice more quickly? A big piece of work around how we wanted to assess the value of genomics. So we did not go into this saying, genomic tests for all. And a lot of countries have done that, right? So you might have heard of places like Genomics England, which has a 100,000 whole genome sequencing program that they've just finished. They now have a target of 1 million genomes over the next few years with kind of a stretch target of 5 million genomic tests. They're doing volume. We wanted to know when was the right time to do these tests because they're not cheap. Our health system is, strapped for cash at the best of times. So when is the right time to do these tests? And then down the bottom, we've got this stream about access to genomic information. And saying access to the information kind of makes it sound like it's just all sitting there somewhere and we just need to kind of, build a pipe to get to it. But actually, the bottleneck in doing this is generating the information, interpreting the information, and then giving people access to it. So that's a little bit of an overview of our program, but what that breaks down to is a bunch of little projects, right? Health systems are big and complex. And in order to change them, you have to pull lots of little levers all over the place. If it was easy to change the healthcare system, like we'd all have done it by now. But we really took an approach of putting lots of little pressure points in a big and complex system to move it towards a genomic future. So I wanted to talk just a little bit at the beginning about the value of genomic tests. So for people who, there's lots of really genomic-y conferences that we go to, and there are people in my team who know so much more about it than I do, and they live and breathe this stuff. But often for people who genomics is kind of this, I don't know, may have never thought about it before, or this thing on the side, people will think a few things to begin with. One, they'll think about things like 23andMe or Ancestry.com, right? How much Viking am I? And that's not really what we're looking at, because you know what, knowing your Viking percentage doesn't actually impact your health, and a lot of those results are scientifically questionable. I'll leave it at that. We actually wanted to know what's the value to patients. There was a lot of skepticism when we started. People would say, oh yeah, you might be able to diagnose someone, but can you do anything about that diagnosis anyway? If you're diagnosing them with a really rare condition, great, now we know they have a really rare condition. So first of all, we had to figure out what's the value for patients in doing these tests. So we did that through picking specific clinical indications, specific patients within those indications, and adding a genomic test to their standard care. So they get whatever they were going to get, plus they get a genomic test as well. And then we do some really detailed looking at how did that change their care. Did they get a diagnosis they wouldn't have otherwise got? If they got a diagnosis, could they do anything about it? What was the outcome for the family? It's an awful range, a large range of things that we looked at. It turns out you don't need many patients to do that either. So for each clinical indication, you only need about 100 tests to know if this is going to work. So you don't need and look, I'm not trying to diss the big national screening sequencing projects. They're doing a different thing, they're generating reference data. But when you're actually looking at does this test work for this patient? You only need 100 patients, and it's not hard to find 100 patients. So these flagships all have really strong academic and clinical teams that sit behind them. They are world experts in these areas. I am not going to even pretend that I can do justice to any of their work, but I'm just going to give you some of the highlights of the outcomes of this work. So the first one is that genomics offers certainty for patients and families, right? So getting a diagnosis is a huge deal, and there's patients that would never have got a diagnosis without these tests. And the number of patients kind of depends on the clinical indication, but in some of them, half of them got a diagnosis they wouldn't have otherwise got. That's a huge change. Depending on the condition, you've got twice as many, 5 times as many, 1,000 times as many diagnoses. So an example of that, I guess, is our epilepsy flagship. So patients that have a particular type of epilepsy, they've tried a bunch of medications that haven't worked for them to control their seizures. And there's a couple of things you can do there, but one of them is, the most radical of them is, they put you in hospital, they put electrodes all over your brain, and they figure out where your seizure is starting, and then they get a knife and cut out that part of your brain, because we can't figure out what else to do about it, right? That only works if you have a particular type of epilepsy. And we had a patient who was scheduled for that surgery, was about to lose a chunk of his brain, and through this genomic test learnt that actually he has a different type. That surgery would not have helped at all. These are really changing patients' lives. And look, that didn't mean that he got offered it. It did mean that he got to keep all of his brain intact, so I think that's probably a good outcome. Genomics testing, and particularly in our paediatric cohorts, we get these little babies coming in with really complicated conditions, and in order to understand what's wrong, they go through some really horrendous diagnostic things that we do to them. And we found that even where the genomic test didn't give an answer, we learnt we didn't have to keep sticking them with needles, right? We could eliminate a whole lot of stuff, and it was a much kinder process. And a big one is that a genomic test is a test for the future. So your genomics, your germline DNA doesn't change. We don't know everything about it yet, but once we have your sequence, we can keep it there and we can go back and reanalyze it. And we're finding that in our undiagnosed cohorts of patients, we're getting kind of a 20% hit rate on diagnosis about 18 months later. So this has led to, and I'll probably come back to this, but I'll mention it now, a Medicare item number has been proposed. It's sitting with the minister waiting for final approval, that we can actually now charge to do that reanalysis. So this is a diagnostic test that is nothing but reanalyzing data that already exists. This is not going to a pathology service, this is not getting an X-ray, this is going to data that we have stored and seeing if we've learnt more about it since we last had a look. Genomics is expensive, but it actually saves money, right? So in our, we have a particular cohort of patients who are acutely unwell. They end up in the ICU, either neonatal or paediatric, very little kids, and often the families are making decisions about whether they're going to palliate and kind of just live out the last few days of their life with their child. And we've realised that we can add a genomic test at that point. We can turn it around really fast. So we have a lab that's doing this really quick, within 5 days, which is an amazing turnaround. This is a complicated test to run. And about 1 in every 40 times you do that, you find something that you can fix. Now, I get that that means 39 kids don't get that option, but 1 in 40 is still amazing. So our first, in this cohort, the first little baby we found like this, had a dreadful genetic condition. They couldn't understand what was going on. They predicted the child would have continued to deteriorate and probably had died in the ICU after about 50 days. They got this genomic test. It was this really rare, weird condition, but really treatable. And they went home within about a week. So not only did this save this kid's life, it saved the heartache of the family, but ICU days are expensive, right? Being in hospital is really expensive. So we can now go to our funders and say, hey, we got this kid out of hospital. We can afford to do a lot more of these tests. So we're actually saving the healthcare system money. The rapid exomes that they turn around, they're charging about $15,000 a pop, right? These are not cheap. In less acute cases, you also know more about the patient and their condition, so you can be more targeted in the surveillance that they have. So a good example of this, I think, is our hearing loss flagship. So little kids born with some form of hearing loss, parents are told this might just be that they won't hear in the same way as other people. They'll have some level of hearing loss. That could be it. Or this could be the start of a lifelong condition that will need monitoring and there'll be other problems in the future. We don't know which one. Good luck, see you in 6 months. That's what parents are being told. And with these genomic tests, we can actually go, oh, no, you've just got hearing loss. That's it. Or, look, there's some other things and we're going to keep bringing you in for surveillance. So we can target who that surveillance is much more effectively and save more dollars. I've mentioned it costs less per diagnosis. And in the absence of that diagnosis, the rest of the care is cheaper. So even if your genomic test is uninformative, then you still don't have to do as many other things. So it's a win all round. The outcomes of these genomic tests change care. So one of the big criticisms of this program when we began is, but are you actually going to be able to do anything with this information anyway? And yes, right? So depending on your cohort, we are changing care in 90% of patients, 75%, 25%, depending on the condition. This actually changes patients' care. And it saves lives. Not as strong an economic argument as you would think. You've got to put some dollar figures around this. But it actually really genuinely saves lives. And so we now have clinical champions in our hospitals that have seen the impact of this on their patients, who are now fighting to say, right, we need to find a way to do this. We need to find a way to do this routinely. So one of the things that we needed to do it routinely was some technology. Now, I don't think I've put in here my example of how genomic data is processed, but I'll talk you through it, right? We talk about big data and how big is data, and there's an analogy that we use. And so if you're going to sequence someone's genome, the reason that sequencing has become cheaper over time is that they found a method of instead reading each chromosome from end to end, they break it up into a bunch of tiny pieces, sequence the pieces, get some really smart bioinformaticians that I don't understand to piece it back together, line it up against like a reference genome, and then figure out where the differences are. So it's not quite as simple as like, oh, here's just this stream of data. It's actually a huge processing job in the middle to do that. And the analogy is if you took, 1,000 copies of War and Peace, which I haven't read. I was going to get the audio book, but it was 72 hours, and I didn't know if I could commit to that. So 72 hours times 1,000 of War and Peace. You shred the whole thing, you piece it back together, you find the spelling mistakes, and then you figure out if those spelling mistakes change the meaning of the sentence. That's the challenge that we have in genomics. So we do whole exome sequencing. Your exome is all the bits of your genome that are turned into proteins, all the bits that get read. And it's about 10% of your whole genome. And in your whole exome, there'll be about 10 to 20,000 ways that you are different to the normal person. I don't know how they came up with normal. Apparently we get a new normal every 12 months. We keep refining that. But there is lots of ways that everybody is different. But obviously, those 10 to 20,000 variants are not all causing disease. Like, they're just ways that we're all different. Finding the one that is actually the one causing the problems is an incredibly complex process. So we thought we'd put in some technology to support that. So the standard workflow for a genomic test is we've got a patient, they take some data, some wet lab stuff happens, they prep the sample, it goes into a magic sequencing box, magic data comes out, right? The bioinformatic analysis happens, it takes all those pieces, puts them back together, and then we do this thing we call curation. And what we mean by that is figuring out which of those 10 or 20,000 variants is the disease-causing one. That curation step is a very manual step. It is a very labour-intensive step. It has to be done by somebody who is incredibly brilliant. It has to be done by medical scientists that really, really know their stuff. It then goes through a multidisciplinary team review. So they bring the person who has done that curation together with the doctor that knows the patient the best, along with a clinical geneticist, and they figure out what this result means. We get a report and we return some results. So that's kind of the general mechanism for how these tests are delivered. So to support that, we put in place a system called GenoVic. So it's our shared clinical system for genomics. So Melbourne Genomics has 10 members. And those 10 members all do different things, but about 4 or 5 of them have pathology laboratories that do these tests. But they're all their own organisation, it's all their own data, it's all their own patients. So we need to have a system that both would stop each organisation having to figure this out for themselves, but also provide enough kind of segregation of data so that they were comfortable to use a shared platform. So we have built something that is collaborative. We have built something that is, you'll be shocked by this, cloud-based. We have pulled together a couple of vendor-backed software as a service offerings, and then we've built a bit in the middle that orchestrates the workflow around those and delivers those into our members. It is built as a clinical first system. Our first job is to deliver clinical tests, but the second job is to get all that data that comes through, get it collected along with the patient's consent to how they want their data used, so that we can turn this around and use it for research, because that's where the real new insights are going to come from. So we had this kind of target architecture vision of what it would look like. We knew we needed patient tools to help patients understand their genomic information. We knew we needed to help clinicians understand how to order tests, when to order tests, what the results meant. But the initial bottleneck in the delivery of genomics was the actual doing of the test. So we have started in this bit in the middle with the diagnostic tools. It's our most important beginning place, not our most important part, but the part that we have to start with. So why did we end up on AWS? I mentioned it was cloud-based. So the first tool that we selected in that space was DNAnexus. So DNAnexus is a bioinformatic platform. It is clinical grade. It was clearly a leader in its space. At the time, and this was a few years ago, I believe they do offer their platform on with other vendors now, but at the time, DNAnexus lived on AWS. So we kind of went, okay, we really like your product. We are happy to trust you on this. Let's go do this. We then selected a tool from Agilent called ELISA Interpret. And because we were already in AWS for DNAnexus, we're like, can you do that? And they're like, yep, sure, not a problem, we can do that. So it wasn't, it was a choice driven by the products that were available to us, not the technology stack itself. So originally we were going to have all this in the cloud, and then we were going to put all our identifier and clinical data down in one of our member organizations. So this was a few years ago, the conversation around how safe is cloud, how secure is it, how does the governance work, can we trust our really special data? We were, it was a few years ago, things have moved on. But at the time, our members were saying, no, we want to keep this in-house. So we were going to build this split architecture and have, kind of have these things talk to each other and okay, yep, all right, good. But at the last minute, this organisation that was going to host all this data for us realised that they were actually also going to have to host data of the other members as well. And they had this kind of epiphany of, that's not what we do. We don't host services for other organisations. We don't want the responsibility of doing this. We can't put service levels around what we do. We're a hospital IT department. That's not our thing. So they kind of went, oh, we don't want to be a cloud provider to other hospitals. And we're like, that's fine, because we know someone that does, right? We're already kind of there. So we actually have ended up moving all of our architecture into the cloud. You never want to re-architect a system at the 11th hour, but that's kind of what we ended up doing. It has turned out fine in the end. It was a little bit stressful in the middle. And we brought in DSG, who were fantastic to help us do this. So this was one of our real enablers in this transition. We have a really strong technical team, but they had very, very little cloud exposure. I think we went in being quite naive. We thought that we were just buying a service somewhere else. What we didn't anticipate is the depth of the product stack that we were going to have available to us. And they still come to me excited every few weeks going, oh, we just found this new thing, we're going to use that. And I'm like, okay, cool, yep, all right. So it's fundamentally changed what we thought we were going to be able to deliver to our members. So this is kind of what it looks like, right? So we have a couple of applications sitting up the top there, the ones I'd mentioned. There's a few things kind of grayed out there that we're playing with and we're bringing into the stack and seeing how they work. The bit in the middle that we had to build was what we call GOS, our Genomic Orchestration Service. So I'm not sure how many of you have ever had to do a hospital integration project, but people kind of get PTSD around these things, right? They're just dreadful. Hospital IT departments are stretched, they're always doing something else. The tech is a million years old, they're just really hard work. So we really had to make the integration into our members as simple as possible. So we did that using this orchestration service, right? It uses a whole bunch of AWS services, and it abstracts away from our members the complexity of the workflow that sits behind all of this. The other thing we did was leverage FHIR. I'm not sure how many people have kind of health background here, but for anyone that wants kind of the potted history, so there's a integration standard that's been around for a long time. It comes out of HL7, and there was kind of a consensus that we're at version 2.x, 2.3, 2.4, and version 3 just wasn't looking great. It didn't really go in the direction people wanted, and then a guy out of Melbourne, Graham Stanton, came along and said, actually, I've got a better idea. It's a fast healthcare interoperability resource. It is now the greatest, latest thing in health. It is being picked up by every major health vendor that there is. It is absolutely going to be the future. We used it because it has some really good information models, but we kept using it because the APIs were fantastic, right? So we now have a series of APIs we expose to our members, really simple stuff. I'd like to place an order. I'd like to know where this test is up to. I'd like the results of these things. And we can change all the stuff up the top without having to impact those APIs down the bottom. It means we actually get to bring in new technologies much more quickly than our members could have access to because we've simplified the integration on their side. So very briefly, I'll run you through what it actually looks like, what happens. So the laboratory does some DNA magic. They put it into a sequencing machine, and they send the FASTQ, the raw file, into, this is obviously an S3 bucket, but anywhere that we can access. So at the moment, all our members are sticking it directly into an S3 bucket that they own, they control. They then send us an order saying, here, I would like this test run. They tell us where the data is, and then our orchestration service says, fine, good. I know exactly what you need done. I'm going to put DNAnexus. I know which pipeline you want, so I'm going to get that out of the shelf. I'm going to take your data. I'm going to stick it through that pipeline for you. I'm going to take the result, and we put it all into a long-term storage, our own long-term storage, so that we can access it again in future for reanalysis or for research purposes. The lab's bucket of data, they can keep there, delete there, we don't care. Once it goes through, we will keep a copy of everything for them. The outcome of that pipeline comes back through our orchestration service, and we put it into the ELISA Interpret, the curation tool. That's the first time a user sees anything. So they go from putting the raw material into the sequencing machine and sending an order from their laboratory system saying, make magic happen, please. All of this happens behind the scenes, and then they get a file popping up in their instance of the ELISA product that says, I am now ready for you to curate. They do their curation magic, and then they send the data back. They say, right, done with this, close off this case. It comes back, and we can send that back into their laboratory systems so that they can generate a clinical report out of that system. The report that comes out of their system. Clinical reporting is actually a really fraught area. You would be amazed at the stringent criteria pathologists have around things like font sizes and positions of doctors' names. We were trying very hard to stay away from a whole lot of PDF formatting. So by just sending the raw data back into their LIMS system, we're like, your report can look however it wants. Go nuts. And all of that part is what is sitting in the cloud. I was going to talk you through a rapid workflow, but I've only got a couple of minutes left, and there's another story I'd like to tell. So I will zoom through that one. It's a slightly different workflow. I guess the story there is just that the modularity of what we've been able to put together means that our members aren't locked into doing this only one way. If they only want to use one of the products in our stack, they can just do that. They send us an order saying, I just want this part to happen. So that's the rapid workflow. I mentioned why AWS, but just as a bit of a, I don't know, an overview of the things that we are currently using. It's not a complete list. I was talking to my software architect yesterday. He's like, yeah, I need to update that slide. We're doing lots of other cool stuff now. But I guess just to reinforce that the depth of the product offering has been a surprise to us and something that we would not have got to where we are without. So, sharing of data. Genomic data sharing tends to fit into two categories. So there are the people that spit in a tube and send it off to 23andMe and don't really think much more about it. Or there are the genomic privacy people who are like, oh, no one can ever know my genomic information. It is so personal to me. It is so dangerous if it's leaked. So there's this real kind of bimodal distribution of people in the data sharing world. But what we know is that we need to be able to do this more. So this is the bit we're going to work out now. We know that the labs, once they've done their test and the data's sitting out in our system, we want them to be able to say, right, that one's been reported, that's gone back to the patient. We want them to be able to say, right, it's completed, and give us a bit of extra data around what came out of that test. We want them to approve it for sharing, and then we want to be able to publish it. And when I say publish, I don't mean everybody. These are clinical samples. We want to publish it in a way that authenticated researchers can find the data that they need to do their research. And then somehow we have to enable them to do that in a privacy-protecting way. So we've been working a lot with Genomics England. The gentleman that runs their research environment is from Melbourne. He used to have my job. I'm glad he's there because now I'm here. So he's been out with us for a couple of weeks, and we're talking to him about how we can leave the data where it is and enable researchers to bring their analytics to the data in a way that's going to protect our patients' privacy, but not hamper the research that they can do. So that's our next challenge. And again, I'm going to skip through a slightly different workflow of that because there's another story I want to get to. Oh, goodness. Right, so what does the public think about data sharing? Because this is the really important bit, right? All this works until you get the Herald Sun story and kind of the tide shifts and everything gets locked down. And we don't want that to happen. I don't know how many people kind of watched the My Health Record opt-out hysteria that went around late last year, but people can get really upset about governments having their data, particularly governments having their data. So genomic data is really, really valuable. 23andMe sold access to their data set to GSK for $300 million, right? I think it's a 4-year collaboration with an option to extend. There is a lot of money in this stuff. There are 26 million people, we think, that have had at-home ancestry tests. So there's some big data sets floating around out there. And if you look at any of the kind of privacy talk, apparently it's all over, right? Apparently everything's been breached and everything's going to end. We should be worried about our genomic privacy. And I kind of used to, not laugh at it, but I think I used to think it was a little bit ridiculous, right? If you have my genomic information, who cares? You don't know who I am. What does it matter? That is not the case anymore. That has shifted really quickly. This was the first case that really shifted that. So has anyone here heard about the Golden State Killer? A few? Awesome. If you haven't read I'll Be Gone in the Dark, would highly recommend. So for the others, I will tell you the story of the Golden State Killer. So this was a horrible crime spree that happened in the 70s, 80s in Southern California. A series of rapes progressing to murders. He terrorised a particular part of the US and then vanished. They'd never been able to find this guy, but they had an awful lot of his genomic information because this is kind of, pre-forensics era. And for years and years and years, people had been trying to track him down. Amateur sleuths have been trying to track him down. And what they did was got his genetic profile and sent it to a place called GenoVic. So GenoVic is a public set of genomic information. You'll do your 23andMe, they'll send you your data, and you decide to send it to GenoVic to say, hey, have I got any relatives out there? So people know their data's up there. But they sent in this killer's DNA, and they constructed a very, very elaborate family tree of this killer. They could find third cousins. We all have a lot of third cousins. But they could find this family tree. And just last year, they have tracked down this man and arrested him. He's in his 70s. He thought that this was a long time ago in his past. So this has really changed some of the thinking about our genomic privacy, right? Even if you have not contributed your data to one of these data banks, your family has. You are in there. You are findable. There's a couple of other cold cases that have now been solved in the same way. There was a journalist that did this as a kind of experiment, gave someone their genomic information, thank you, their genomic information and said, figure out who I am. It took 2 hours to figure out who they were, right? Our genomic privacy is we don't have genomic privacy anymore. So we also have the My Health Record stuff, right? And there was a story that came out at about the same time saying the My Health Record's storing genomic information, but it's not ready. First of all, the My Health Record is not storing genomic information, right? It's storing pathology results. So if you've had a genomic test, the result of that test might get in your record, but your genomic information, as in your DNA sequence, not going in the My Health Record. But this article kind of make it sound like it was, right? Your genome is the complete set of genetic instructions in your DNA, and that's in your My Health Record. So then you get these kind of, I don't know, never read the comments, but still, you get these kind of comments. Never has the saying, Big Brother is watching you, been more apt. You know, now we know what was presented as a centralised system is all about a national database with unfettered police access. What a massive invasion of privacy. You know, the Stasi would be envious. And this guy is going to have his DNA removed. So the public debate about this is not always the most balanced. And for us, our driver here is that we don't want people to be scared to have a genomic test. Because what we've shown is that genomic tests change lives. And we would hate to think that there are people coming in going, oh, well, this genomic test could really help me, but I don't know what's going to have within the information, so I'm not going to have one done. That would be a worst case for us. So we went out and asked our patients, how do you feel about this? And patients are very different. So people with an active health condition or parents of someone with an active health condition are very different to like people who are perfectly well and are just kind of wanting to know, you know, whether they, you know, were related to the guy down the road that kind of looks a bit like them. So this is some work done by Melissa. She's a fantastic evaluator. It's not my work, so I feel like I need to give credit to her and to the team. What we did across all those flagships was send out surveys to those people saying, how did you feel about this process? So, first of all, we asked them, what did you agree to? We wanted to make sure that people remembered, right? Because how many times have you like got some text message spam thing and you're like, I didn't opt into this. We didn't want people to be like, I didn't opt in to share my genomic information. What are you talking about? And we're like, yeah, you did. You signed the form. So the first thing we did is check they remembered. And yeah, most of them do recall that what they had selected in terms of sharing. And most of them understood about the sharing of their anonymised genomic data. A term that we don't use anymore in genomic data, I should update the slide. We de-identify your genomic information. We cannot anonymise your genomic information. Most received enough information during the process, so they felt that they were well informed about what that data was going to do and had no remaining concerns, so also really good. Then we asked them, how easy do you think it is to be re-identified, and how concerned are you if you are, right? So how hard is it and how much do you care, really was what we were asking. And most people, and my numbers are vague because this work is in publication at the moment, but most people either are just not worried whether they think it's easy or difficult. They're like, yeah, I don't care. One of the differentiators here is that lots of these people have active health conditions. So saying to them, oh, your genomic information might expose your health condition, they're like, I'm in the hospital 5 days a week. I've seen 10 different clinicians. I've had to tell my boss, or my family knows because they're like, what do you, like, everyone already knows this information. So it's a different risk reward there. There are some people that are concerned but think it's difficult. That's an interesting group because it's not as difficult anymore. But then we've got a really concerned group, and they're the ones that we have to keep an eye out for. Where there were parents of a child with a hereditary condition, there was a bit more concern because obviously there's some kind of longer family term things going on there. The really interesting thing is who they trust with their data. So they trust our alliance members, hospitals, effectively. They trust the Australian not-profit, but way down the bottom, below the pharmaceutical industry, is our governments. We have a real trust issue with our governments. And I've heard the Australian Digital Health Agency, I've heard Tim and I've heard Jim talk about these problems. We need to rebuild trust in order to be able to better support people in their healthcare, given that our healthcare is predominantly government funded in this country. We also ask people, how do you want to opt in or out of research in the future? And effectively, we don't have a model. People don't know. They don't know if they want to be asked every time. They don't know if they want to not be asked every time. It's an area of work that we need to think about some more. So overall, most are informed, accepting, but there's a couple of residual concerns. So the privacy impacts here are not overwhelming the people who need these tests at the moment, but we're going to keep working in this space. So if I have one minute, is that all right? I just wanted to tell you the story of Louis. So Louis, when he was very little, he got very sick, and he was being seen by some of the best doctors in the country who could not figure out what was wrong with him. Through a Melbourne Genomics flagship, he got a genomic test. He got a diagnosis. He was diagnosed with something called biotin and thiamine-responsive basal ganglia disease. I assume you've all heard of it. He is one of 40 people in the world to ever get this diagnosis. Without treatment, he would have continued to deteriorate. He would have lost his speech. He probably would have died before he went to primary school. But the cue's kind of in the name, biotin and thiamine responsive. Biotin and thiamine are those B vitamins they put in your breakfast cereal. He is now on an 80-cent a day B vitamin, and he is now a happy and healthy little boy. That is the treatment for his condition, and we would never have known that without this genomic test. Our members, I will say thank you, and thank you very much for your time.